Hello, welcome everybody to our third sessions. We have Stanford medical doctor, Dr. Grant Smith here with us, and he will be talking about living your best life. Dr. Smith, floor is yours. Thank you for joining our community day. We're so honored to have you.
Oh, Tina, thank you so much for inviting me. It's really a pleasure to be here, and it's always great to get to talk to community members a little bit more about what it means to live your best life, and especially what that means in the context of potentially living with an illness. And again, my name's Grant Smith. I'm a palliative care doctor at Stanford, and I work both in the hospital doing consults or seeing patients who are hospitalized for their medical issues. And I also work in our outpatient clinic where I see patients in an outpatient setting. And nowadays we're doing a lot by telehealth or video. And it's really a pleasure today to talk about this concept of living your best life, and especially in the context of living your best life when you have an illness. We'll talk more about what palliative care is in a moment, and that's the specialty of medicine that I practice, and it's a resource really that can help people live their best life. Before I do that though, I just want to point out two resources that are on this title slide. Our palliative care department has put together a website that has a lot of information about what palliative care is and the services we provide, and you're welcome to check that out using the website that's listed here. And then we also are on Twitter. So if you're on Twitter and follow anything in Twitter, you can follow us at Stanford_PC. We put on events like this in the community pretty regularly. We're trying to kind of get the word out about our services, hoping that we can demystify some of what palliative care is. With that, I'll just say that when we think about this idea of living our best life, a lot of us think about some images that might look a lot like what some of these images are showing. Spending time with friends and family, eating delicious food. I think pizza would be very high on my list of what it means to live my best life. Maybe it's going on a hike, being outdoors, engaging in sports or activities, spending time with our children. Maybe it's things that aren't necessarily pictured here, participating in church or connecting with our faith or spiritual practice. Maybe it's caring for loved ones or spending time with our pets, participating in our jobs or our work. All of these things, of course, are things that contribute to helping someone live their best life and feel like they're living their life to the fullest. Unfortunately, for some people, though, an illness may get in the way of that. And especially as people get older, or if multiple illnesses are kind of combining, that can really get in the way of living your best life. And whether that's through physical symptoms like pain or nausea, or emotional symptoms like depression, anxiety, or just stress from dealing with an illness, or even sometimes there can be spiritual concerns that may make it difficult to cope, that those are all challenges that can affect our quality of life or being able to live that best life. The next hour, what I'm hoping we can spend some time talking about, though, is how we can try to regain some of that quality of life if you are living with a difficult illness. And this information might apply to you if you're someone living with an illness, or might apply to a family member or a loved one that you're helping to take care of. Or maybe this is something that isn't at all a part of your life yet, but it may be helpful in the future if something like an illness does come into your life or a loved one or family member's life. And so we'll talk a little bit more about this medical specialty called palliative care and how it helps to really help achieve that goal of helping people live their best life when they're living with an illness. Along the way today, I really want to make this time as useful to you all as possible. And I'd love to use the chat as a way for you all to ask questions and communicate with me during this talk. Thank you. I can see there's already a question coming up. I'll keep an eye on the chat, and we'll take regular breaks to try to answer these questions as we go. As part of today's session, we're really hoping that you might be willing to help us to understand if the content we're presenting is helpful for you by filling out a survey both before we jump in too much in the content today, or right now, and after the presentation. I'm just going to go ahead and put a link to this pre-session survey in the chat, and you can just click on that and it will take you to a survey that will ask you some questions about sort of what you know about palliative care and a little bit about you, so we can know who's in attendance. It just takes about 5 minutes or so to complete. And all your responses on this will remain anonymous if we ever use any of the information for a report or for a publication. And for those who complete the survey both before the session and after the session, there'll be a raffle for a $50 gift card to say thank you for your time. We also are offering on the post-session survey, you can opt in if you'd like or would be willing to give us some more feedback about the session through a telephone interview with one of our team members. And that would just be about 15 minutes or less, just talking one-on-one with someone about how you found today's session. Completing these surveys just really helps us be able to refine the content we're presenting to the community, make sure that we're communicating clearly. And it also helps us report back to the folks that support my time and my colleagues' time to do some of this work, that they continue to support us. So if it's okay, what I'll do is just ask those who are willing, if you could click on the link that's in the chat to take this survey, and we'll just give about 5 minutes or so to complete that. And then we'll jump into our content. I'm going to play a little bit of background music for us, just so we can have something to listen to while we complete our surveys. And then we'll be back in just a few minutes to jump more fully into the content. So thank you so much. Give folks just about 1 more minute to wrap up your survey if you're able to participate in that, and then we'll jump into more of the content just shortly. All right, thank you all so much for those who were able to participate. And if you weren't able to, no worries at all. Hopefully you just had a few minutes to yourself to quietly listen to some relaxing music. We'll take that as well. So let's jump in a little bit more to talk about more about what we'll be speaking about today. And this is just a roadmap about some of the questions that I'm hoping we can help answer for you. It's really, what is this thing called palliative care? How is it different from other parts of medicine that you may be more familiar with? And when and how can someone benefit from palliative care? We'll talk more about too, like what does it do or how does it help people live their best life? And then at the end, we'll also just talk about and clarify the difference between palliative care and hospice. If you haven't heard of hospice, haven't heard of palliative care, that's all okay. We're going to try to clarify that today for you and talk about when those services may be helpful and how each of them may help to live your best life. So let's start with this question, what is palliative care? And I may just ask for those of you who are able to communicate in the chat, if you have heard of palliative care, or even if you haven't, when you hear that term, what comes to mind? Does that bring up anything for you or anything that you think might relate to palliative care? Feel free to put anything in the chat, or if you feel comfortable unmuting, you're welcome to say out loud. Great, I see. Thank you, Tina, for in the chat saying it's about people getting sick. I think we'll talk more about that, but certainly it is part of helping someone who maybe is dealing with an illness. Thank you, Tommy, mentioning it could mean homebound. Is that something that palliative care might be a part of or intersect with? These are great ideas. Give a few more seconds if there's anything else. Great, thank you for answering here. Carol saying no heroic measures, long-term care, not expected to get much better. Tommy saying extended care. These are great. I think this is really helpful, that some of the ideas that kind of get wrapped into palliative care, I'm so glad that you all are here. I'm hopeful that we can help really clarify some of these questions for you. And I see one more idea here, no hope left. So I'm hoping we can help to clarify some of these answers I think are related. And I'm hoping that we can help clarify maybe some of the areas that might be confusing, or even some misconceptions that can go along with this term palliative care. Let's start by talking about how is palliative care different? And what I mean by different is how is it maybe different from some of the other medical services or clinics that you might be familiar with? And I think one of the things that we do a little bit differently is that we try to see the person beyond the disease. And I think that this turn of phrase, a person living with cancer versus a cancer patient, is just an example of kind of the phrasing that reflects the broader way that we think about working with individuals and their family members. that it's a person-first strategy, not a diagnosis first, but we think about the person and all of their individuality that comes with that as someone who happens to have an illness that might be getting in the way of them living their best life. And again, it's not that other doctors or other offices wouldn't do this. It's just that this is really our focus. Another way that we're different is we think about providing a holistic or a whole person approach. And in this diagram, you can see that putting that person and family or loved ones or whoever family friends might be really at the center of care. And we acknowledge that a difficult illness, whether that's cancer, heart failure, lung disease, liver disease, a neurologic disease, or dementia, that a difficult illness like that can certainly affect the body and can cause physical symptoms like pain or nausea or bowel problems, but also can cause things like depression, anxiety, or other psychological stress. We mentioned a little bit earlier the spiritual, or sometimes we use the term existential. Those might be questions or concerns like, why is this happening to me? How do I make meaning in this? And then also practical concerns about maybe how do I pay for care, or how do I get back and forth to my visits? And so in palliative care, we try to acknowledge and address all these different components of life that can be affected. Just another diagram to say that, again, we kind of think about the person and the family versus focusing on the disease or a particular organ. And unlike doctors, like a cardiologist, for example, or a heart doctor, they're really focused on the heart, or a cancer doctor or oncologist is really focused on treating the cancer. We don't specialize actually in a particular disease or part of the body. Again, we think about specializing in the whole person so we can help think about, gosh, what helps this person to live their best life? How can we help them achieve that, even with all that's going on with their health? And thank you again. I can see some questions coming in the chat. Feel free to continue to ask those. We'll get to some of these questions in the presentation, and we'll have time at the end to address them as well. To help address all those different aspects of life that can be affected, we work as a team. As a doctor, I can't do it all on my own, and I really rely on other members of the team to help support all those different aspects of life that can be affected. But as a doctor or as a nurse working in palliative care, we help to prescribe medications that might help with some of those physical symptoms. We also can help with making medical decisions. That might involve figuring out, do I want to pursue this treatment for my cancer? Or what would it mean to be on dialysis? We also spend a lot of time coordinating with other doctors. We are fully aware that medicine is now a very complex system where there can be a lot of different cooks in the kitchen working on helping someone feel their best. And sometimes we help to coordinate among the doctors and make sure we're all on the same page and that we're moving towards the same goals. We also work with social workers who help provide emotional support. They also can help support your loved ones or family members, or if you're a caregiver, we're here for caregivers too. We know that that can be quite a stressful position without often a lot of things. Social workers sometimes help people to get medical equipment they need, like a walker, a wheelchair, a commode, help to address things like financial concerns. We also work with chaplains who help with those existential questions we talked about earlier. They can offer prayers and blessings, and often they're helping regardless of what someone's faith background is, or even if there's not a particular faith background, if someone's spiritual or connects with nature, they'll help to connect on whatever it is that someone finds deeper connection to. I want to take a moment just to provide a definition of palliative care that's sort of the most commonly accepted definition. And in the slides to come, we'll break down what some of these quotes mean exactly. But just to describe this definition first, that palliative care is specialized healthcare for people living with a serious illness. And this type of care is focused on providing relief from the symptoms and the stress of the illness. And that goal is to improve quality of life or to help someone live their best life for both the patient and for their family, loved ones, caregivers. It's provided by a specially trained team, and palliative care specialists, like I mentioned, we work together with your other doctors to provide an essential and extra layer of support. And palliative care is based on the needs of the patient, not on the prognosis. And it can be appropriate at any age and any point in a serious or difficult illness, and absolutely can be delivered with curative treatment. So that last part we'll come back to, but I know that some of the comments that were made earlier was wondering if, does this mean there's nothing left to do or there's no hope? And I hope today that you walk away realizing that that's not necessarily the case, that we're an extra layer of support, and we can see patients who actually are going to be completely cured by their illness. And we just help make sure that their life is as good as it can be while they're going through their treatments. Just to break down some of the words that were used in that definition, because I think even for me, they can be a little bit vague and somewhat confusing. That living with a serious illness, often I think of that as being a difficult illness. And some examples that we see are really any illness that could limit someone's lifespan. Often that might be a diagnosis of cancer, or that an organ is not working well and is actually failing. So heart failure, or liver, kidney, or lung failure or disease, dementia, other neurologic diseases like Parkinson's or ALS, or even if someone is just needing to be in the hospital more than they're living in the hospital more than they're living outside of the hospital. That can be another time where we can try to help figure out how can we make life a little bit better. Or if someone is becoming more dependent on their family members or loved ones, they're not able to do as much for themselves as they used to be able to. These are all examples of what I would consider a serious or a difficult illness. We've talked about the relief from symptoms and stress of an illness, and some of what that means can be helping to address those physical symptoms like pain or difficulty breathing, nausea, constipation, those emotional or psychological symptoms like anxiety, depression, or stress. We also help with other common issues like fatigue or exhaustion, low appetite or weight loss, nerve pain or neuropathy, and then helping out with caregiving. How do we really accomplish this? And it's taking an approach that we recognize that any symptom that someone has, whether that's, let's take pain as an example, is that it can be a complex thing. There, of course, are physical components, nerve endings that might be irritated, sending signals to the brain that tell us that there's pain. But in addition to that, pain can also have a big emotional component. That certainly is based in some of the neurochemistry happening in the brain, but pain is also emotional. It can be scary. Pain might also represent that, does this mean that an illness is getting worse? And so we recognize that in order to treat a symptom fully, we need to really use multiple strategies and address all those different components of a symptom in order to really help get that symptom under the best control possible and make it as good as possible. Again, for the goal of getting back to living the best life possible. Sometimes in palliative care, we're also helping people live their best life by helping with some of the difficult medical decisions that sometimes can come up when you're living with an illness. That might include something like advanced healthcare planning. For those who haven't heard of that, that often involves assigning someone who might make medical decisions for you if you were ever unable to do so for yourself. It can include completing something called an advanced health directive, which is sometimes called a living will, or completing something called a pulsed form, which expresses your wishes on paper about some specific medical interventions. And often we're just helping to weigh different treatment options that you may or may not be facing in the course of an illness. Talk about being an extra and essential layer of support. And that's really to say that if you see a palliative care doctor, it doesn't mean that you're not able to see your other doctors. You would still have a primary care doctor. You would still see your specialist, whether that's a cancer doctor like an oncologist, or a heart doctor like a cardiologist. So we're really an extra layer that coordinates and works with your other doctors. Another big statement I think that can be new and different information for people is that palliative care can be provided at any age and at any stage of an illness, and absolutely can be provided alongside curative treatment. So you can see I'm here in my clinic room today, and even today I just saw someone who they actually are basically in remission from their illness, that there's no sign that they have a disease active right now, but they've had some stressors from going through treatment. And so I'm still seeing them to try to help with their ongoing coping after going through that difficult illness and a difficult treatment course. So I see people who may be newly diagnosed, as I mentioned, cured, but with ongoing symptoms, and absolutely seeing people who are going to be fully cured from their illness, but we're helping them get over a difficult hump in the road or bump in the road, where maybe they're having difficult symptoms from the treatment that they're having or from the illness that ultimately they may completely get over. We certainly do also help when people have an illness that we can't cure, but maybe we're able to slow the progression of that illness, and we still work diligently to try to help get their symptoms under control. And we do help with people who are living with their illness and maybe they're too sick to get more therapies, but there still is a lot of care that can be provided and things we can do to help them live their best life. So I hope that just helps to clarify that we really aren't just here for at the end or when someone may not have other treatment options, that we really can work in parallel with other doctors to make life as good as it possibly can be while someone is living with a difficult illness, and absolutely while they're getting treatments that may even cure that illness. In palliative care circles, we sometimes joke that if we were a pill, we would be the next big blockbuster medicine out there. And the reason we sometimes say that is from this New England Journal of Medicine, which is sort of the premier academic medical journal in medicine. And there was a study done where they randomized patients to either get usual care, meaning that they just sort of got their regular cancer care, they may or may not see a palliative care team, or from the very start when they got diagnosed, they would see a palliative care doctor on a regular basis. And as part of that study, it showed that the people who got that early palliative care actually ended up living several months longer than the people who didn't get that palliative care. And if this were a medicine, a pill that you could bottle and give to someone who had a difficult illness, this would be huge. And certainly there's kind of a still figuring out why exactly this happened and what is it that helps people to live longer when they get palliative care. But there are certainly several studies that have repeated this result. And perhaps more importantly, there are a lot of studies that have shown a lot of additional benefits in addition to that survival benefit that study showed. It's well been established that palliative care can help improve quality of life. Again, that living the best life possible, help with symptom control. People feel that their spiritual well-being is improved, better control of psychological symptoms, and more satisfied with their overall care. Sometimes there can be even fewer hospitalizations or fewer hospital days, and caregivers often feel that they have more support. I've been talking for a bit, and I want to give you all a break from my voice and to hear from a few other people about their experiences with palliative care and what they found helpful. So I'm going to play this video that just highlights some patient experiences as well as some other palliative care team members.
Palliative care is person-centered care. Everything about it is bringing the person into the conversation.
We talk to the patient, we understand where they're coming from, we understand the family dynamics, we understand the culture and the environment, and we try to figure out which of these treatments that we have available fits that.
It's fantastic because I feel like we're a team, a baseball team or a soccer team, and we're all these different moving parts trying to care for our patients.
It seems like they're more really interested in me. You know, it's like more of a family. When I see them, I'm comfortable when they call me.
She was the only doctor that came and held his hand. And that to me is this compassion that comes from being a palliative care doctor.
It was really because I wanted to improve people's lives. And that happens some days in other fields of medicine, but it's not your primary goal every day with every patient as it is in palliative care.
The people are wonderful, really wonderful. And it's just a very warm, accepting, positive environment. And for me, that was what I needed.
All right, hopefully that was helpful just to see a few other people talk about what palliative care has been like for them. And I'll pause here just to answer a few of the questions that have come up in the chat. There's a great question here about why can't palliative care do home visits, since many people who don't qualify for hospice are still quite disabled and not able to get to an office visit or be treated via telehealth? And thank you so much, Donna, for asking this question. And there is some variability in which palliative care teams can provide home-based palliative care. Unfortunately, it is a little bit more of a rare service, and our team at least at Stanford, we unfortunately don't offer home visits, but we have been offering telehealth for some time. And right now with COVID still going on, most of our visits are via telehealth. There are some services in the Bay Area that do provide home-based palliative care. Some of the ones that I know of include UCSF, has traditionally had a home-based palliative care program for individuals living in San Francisco. The Palo Alto Medical Foundation also provides some home-based palliative care services. And there are some hospice agencies that also provide palliative care, and sometimes they are well equipped to also provide home-based care. So whether or not there's a home-based component to a palliative care team does depend a bit on the individual team and the institution's resources to provide that type of care. I certainly wish that everyone could get home-based palliative care, and unfortunately, we just don't have all those services at every institution that offers palliative care. And I'll be talking a little bit more about some of the other institutions and other ways to find a palliative care provider here in the next few slides. One question that people often ask is, how do I access palliative care? And often the easiest way to get in to see a palliative care provider is to ask for a referral from either a primary care doctor or from the primary specialist who may be helping to take care of you or your loved one. So that might be the cardiologist or oncologist. And sometimes people can get referred to us from the inpatient side if they've been hospitalized, or from an emergency room provider. I do want to say that similar to many people in the community, and even outside of medicine, that there's still some confusion about palliative care, and that some people do feel that it is, or have the misperception that it may only be for people who are facing the end of their life. And that's not accurate. I hope that today I've been able to explain more about the services we offer and the types of individuals that we see. And I just say that if you are talking with your doctor about palliative care and they feel like maybe it's not something that could benefit from you, feel free to use this talk or something you learn from this talk to help to remind them that we do see people who are not just facing the end of their life, and that we can help to manage those difficult symptoms or help with trying to navigate difficult medical decisions. When to bring up palliative care, I think is often a question that we get, and a good one. I think that if you're living with a serious illness, which could be one of the illnesses that we mentioned earlier, and again, remembering that a serious illness, I sometimes think of calling it really a difficult illness, an illness that is impacting multiple parts of your life. So maybe it's affecting both your body, and your psychological well-being, or you're having lots of existential questions and lots of emotional distress, when multiple aspects of your life are being affected, I think that's when our team of doctors, social workers, chaplains can be most helpful and most beneficial. But again, that could be with difficult symptoms, difficult decisions, or difficulty coping. All those things could make a good time to bring up palliative care to your other doctors to see if it could be helpful for you. Some people may wonder, well, what words would I use to bring up palliative care? And you could always say, I wonder if palliative care might be a good extra layer of support for me or my loved one if you're a caregiver. Would you be willing to refer me? Or if there's something in particular you're hoping we could help out with, you could ask, I'd like to get some additional support for whether it's pain or nausea. And I'm wondering if a palliative care consult might be helpful. And then you could also say, I use this talk. I went to a talk by a palliative care doctor. Do you think seeing a palliative care team could be helpful for me? So those are all ways you could potentially bring up palliative care to your providers if you feel like it could be helpful. This addresses a question that I think Tommy had asked in the chat was, does palliative care get covered by insurance? And this is a great question. And palliative care is typically covered by insurance like any other medical specialty clinic. So for example, if you were to go see a cardiologist or a heart doctor and you pay a copay there, you may have a copay when you come to see a palliative care doctor within your institution. Similar to sort of all other sort of medical care, that finding a palliative care doctor that your insurance contracts with is really looking with your insurance company and often going to the insurance portal or calling them to ask if they can give you a list of providers with palliative care, palliative medicine, or hospice and palliative medicine. I did this for my own insurance plan just to see what it's like. And I found that using these search terms like palliative medicine, hospice and palliative medicine, or palliative care would get me a list of palliative care doctors that would be contracted with my insurance. Interestingly, in California, SB 1004 was passed several years ago, which really mandates that there needs to be access to palliative care for individuals who are covered by public health insurance, like Medi-Cal or Medicaid. And there are certain conditions that it mandates that for, including cancer, heart failure, end-stage lung disease. So access to palliative care has really been improving recently, and getting coverage by your insurance should check with the insurance company, but should be covered like other specialty medical services. I wanted to talk a little bit about palliative care and hospice, but before I do that, I just see another question in the chat that's come up, and we can take a pause here to answer that. Carol is just asking for our Kaiser medical coverage to cover home health or SNF. Do we have to be admitted to the hospital and apply within 3 days? So Carol, thanks so much for your question. And in terms of palliative care, there's not a requirement for being admitted to the hospital for any amount of time. And for coverage for a skilled nursing facility or for home health, those coverage requirements are a little bit different. Certainly a home health coverage, which would be more of like a nurse or physical therapist to come to your house to help, that can be ordered from an outpatient visit. And then I'm less certain about what you would need in order to have a skilled nursing facility be covered by your insurance. It may be good to touch base with one of your Kaiser providers who might know more about the Kaiser coverage, as that might be unique as well. I think just Carol's question is a good reminder that sometimes, and I think in some of the comments initially, people were wondering if home health is part of palliative care. And I would say that, again, that home health is a service that is separate from palliative care, and home health provides nursing, physical therapy, occupational therapy, sometimes a social worker, and sometimes a home health aide. They would really be following sort of doctor's orders to provide help with rehabilitation, potentially in the home. That's fairly different than a palliative care service, which would be typically include a medical provider like a nurse practitioner or a physician or a physician's assistant who would be able to provide medications, as well as connecting to an interdisciplinary team that would include a social worker and chaplain. So if you are able to access a home-based palliative care team, both those services may be able to come to your home, but their focus and the services they provide would be a little bit different. And again, some palliative care teams, like our one at Stanford, unfortunately, we don't offer home visits, so we wouldn't be able to provide care directly in the home, but could do care through telehealth visits through a computer or another electronic device. So I hope that helps answer some of the questions. Again, feel free to continue to ask some more questions in the chat. And for now, we'll move on to talk a little bit more about this concept of hospice that is often closely linked to palliative care, but they are separate and different. I think this diagram is one that I keep in my head to help me remember kind of the relationship between palliative care and hospice. And I think of palliative care as kind of this big bubble or like an umbrella term that encapsulates this philosophy of care of trying to help people live their best life regardless of their health. But as we mentioned earlier, palliative care can really be provided all along an illness course. It can be delivered at any age, any stage of an illness, and right alongside potentially curative treatment. Hospice still has that same philosophy of care of trying to help people live their best life possible, but it is the care that is really focused on the last phase of someone's life and people who are facing the end of their life. So I'll talk just a little bit more about what hospice is and differentiate that from palliative care. And when I think about hospice, I often think about it in these three kind of categories or ways to think about it. Think of it as a philosophy of care. Second, it's actually an insurance benefit. And three, it's a set of services. So we'll go through each one of these. As a philosophy of care, hospice really focuses on helping someone be as comfortable as possible. We sometimes call that comfort-focused care, meaning that comfort is really the number one priority for that person's healthcare, and that other priorities are going to be secondary. So a hospice approach would often be asking the question, does this intervention, medication, lab test, whatever it may be, does this component of this person's care help them to be more comfortable today? And if that answer is yes, they would absolutely want to do as much of that as they can. So if that's a medication that helps someone be comfortable, they want to use that medication to accomplish that goal. But if there's a medication that doesn't really help someone be comfortable, they wouldn't necessarily continue that medicine. So it's really a comfort-focused approach. The other part of the philosophy of hospice is that they really want to deliver care where the person is most comfortable. And some people think that hospice is a place that you go, but the overwhelming majority of hospice care is actually provided right in someone's home, and it is home-based care. And it's probably one of the most robust home-based care programs that we have in all of healthcare. They are able to provide care, though, if someone's living in an assisted living facility or a nursing facility, and they can even help people transfer between a location that's in the home or out of the home if that's needed. In rare cases, there are also hospice houses, which is a location that someone goes to spend their sort of final days in the last part of their life in a facility that's run by the hospice. But that tends to be quite rare, and there aren't very many here in the Bay Area. As an insurance benefit, hospice is really covered by almost all insurance plans and certainly by Medicare and Medicaid. And it's the insurance guidelines that mandate that individuals who enroll in hospice have an estimated prognosis or a time left to live to be 6 months or less. And it typically does not cover cancer-directed therapy like chemotherapy or immunotherapy. That's really from the insurance benefit component. Well, I would say that discussions about specific treatments is always possible. And so if hospice is something that feels like the right approach for you or a loved one, it's always good to meet with the hospice agency directly and talk about the types of treatments that you're thinking or wanting and what they would be willing to continue. And then finally, as a set of services, hospice also operates with an interdisciplinary team, meaning that they have a doctor, nurses, social workers, chaplains, volunteers, and home health aides. As we mentioned, it can be home-based care if that's the right fit. They offer a 24-hour nurse call line. So there's help kind of 24/7 where you can call a nurse to get advice about managing symptoms. And they even have the ability to send an on-demand nurse to the home if symptoms are really not well controlled. There, of course, can be some variability between hospices about how quickly, but often within 24 hours. And then, as we mentioned, if someone needed to transfer to a nursing home, that's also possible within hospice. And they prescribe and provide all the medications that are needed, as well as equipment that's needed, like a hospital bed or commode or wheelchair. One thing to know is that hospice doesn't provide 24-hour care unless someone is in a hospice facility, where often there still may be a cost associated with the care that's provided there, whereas hospice delivered at home is typically fully covered, but doesn't provide 24-hour care for an individual. So I know we've thrown a lot of information at you, and just wanted to wrap up here by just saying that the take-home message really is that if you're facing difficult medical decisions or difficult symptoms, palliative care is really here to partner with you to improve quality of life and to try to navigate difficult decisions. Our palliative care team at Stanford is certainly available, although there are a lot of great palliative care services throughout the Bay Area. We have clinics in Palo Alto, San Jose, Emeryville, and Pleasanton. As I mentioned, we provide in-person as well as video visits. And you can ask your healthcare provider for a referral. And we also accept self-referrals by calling our office. We can help give you guidance on that. Again, the Bay Area is actually very blessed to have quite a few robust palliative care programs. This is a map showing where some of those are located. This is not an exhaustive list, but as a resource, this website, getpalliativecare.org, is really the clearinghouse for palliative care programs to register. And you can put in your zip code and you can click if you're looking for a home-based, clinic-based, or inpatient palliative care team. And it will show you all the results of the palliative care teams that would service your area. So this is a great resource, no matter where you live, even across the country, to find a palliative care team near you. I wanted to wrap up by just having another video, just telling the story of a patient who was receiving palliative care. I think is a good example of some of the ways we can help someone get back to living their best life. So I'll play this video, and in the meantime, if you have more questions, I see some coming in, please feel free to continue to put those in the chat, and then we'll have time to answer your questions next.
Neuropathy it's a type of nerve damage. It affected my feet, my hands, and that's how I make my money. So I've been out of work for more than a year and a half.
I met Debbie when she came into the hospital with an acute pain crisis. She was really going through a lot in terms of just living with this new diagnosis, and then to be suffering from symptoms sort of related to the treatments so that she can live with the diagnosis.
With me being in the pain, I just shut myself out and just stayed in my room. The most they saw of me was to come out and get something to eat and go to the bathroom.
She was really crippled by this neuropathy. And you see, she does hair, and that was one of the things that came out when we were in the hospital. You know, sort of what bothers you the most about this pain.
They talk to one another, and they come and they talk to me with each other. Not, you know, they're talking just in a conference among themselves, but they include me in that conference that they're having with one another in terms of the medication I'm on, how's the medication treating me, how I'm sleeping, how is my quality of life.
I mean, she's such a beautiful person and so lovely and social, and you can imagine for her not to be in that world, it really robs her not just of, you know, financial security, but her identity. And I think it's powerful to think that if you can give her some of that back by controlling her pain, you're really allowing the miracle of her treatment for her myeloma to fully realize itself.
I would not be back sitting in this chair right now if it wasn't for the program. I would be lost without them right now, lost.
She's a perfect example of how palliative care can help.
I feel I'm in the driver's seat because they're really concerned with how I'm feeling.
All right, hopefully that was helpful to hear more of the words of a patient who's worked with a palliative care team. And with that, we'll wrap up. I will put the link to our post-session survey, but we'll definitely have time for questions, so we'll stick around to answer more questions. Again, just a reminder, if you're able to complete this survey, it would help us just to know how today's session was or was not helpful for you. And your responses will remain anonymous if we ever use this to report about the experience of doing these. And again, there's an opportunity to provide one-on-one feedback through a 15-minute telephone interview. So you can sign up for that at the end of the survey. You can also sign up for our listserv if you'd like to get more information on future educational opportunities about palliative care. And there is the opportunity to sign up for the raffle for the $50 gift card if you were able to do the pre-session survey and the post-session survey. So thank you all so much for your attention and your questions. And it's been such an honor to be a part of this and to be here with you all today. I will stop sharing my screen and then we can talk more about some of the questions that are in the chat, and happy to field questions for the time that we have left. So I see that one of the questions here was someone's letting us know that their mom was maybe given a phrase to use to not have to leave home for medical care, wondering what that was. Is it serious and inconvenient, damaging, difficult to go to clinic? Well, thanks for sharing that. I'm sorry that your mom is having that difficulty leaving the house. What I would say is that if you're ever in a place where you're not able to leave your house for a clinic, we sometimes call that homebound, meaning that you're not able to get out, or it takes a lot of additional support to get someone out of the home. And talking with your providers, if they're able to accommodate having you be seen either by a home-based care team or using telehealth would certainly be a reasonable request. I think the ability of different clinics and providers to provide that may be variable, so it's a little bit hard for me to comment on your specific situation, but I think alerting your providers to the situation would certainly be a good first step. Tommy's asked a great question here about chronic diabetes. Would that be something that would qualify for seeing palliative care, and what would palliative care do? What I'd say is that it depends a little bit. If someone has diabetes that's relatively well managed by a primary care doctor or endocrinologist, there may just be that a lot of time with diabetes, you're managing your blood sugars and titrating the medications like insulin or other oral medications to keep the diabetes under control. When I think someone with diabetes might benefit from palliative care would be if the diabetes is starting to cause a lot of complications, like maybe there's a lot of nerve-related pain, and that pain has made it, or numbness has made it so that you're not able to do as much for yourself the way you used to. Or if there are complications from the diabetes, like having infections, or it's requiring you to go to the hospital multiple times a year. Those are the types of things where I think that the illness is really expanding to impact more than just beyond managing your blood sugar and more than just a kind of manageable chronic condition, that you're starting to have more complications and it's becoming more burdensome to live with that illness, that we'd be able to meet and see how we might help. Some of the ways that we sometimes could help for something like that, if someone has pretty advanced diabetes and a lot of complications, could certainly check in if there are things we could do to help with nerve-related pain, which is sometimes a common complication of diabetes. We might help get connected to even other pain management specialists that could help out. I think the other main way we could help is with some of that part of managing those medical decisions that might come. How are you feeling about the care you're getting? Is going to the hospital providing the benefit that you're hoping for? Thinking through, what would you want your care to be like if the diabetes were to progress or cause more complications, and thinking through some of the future of your healthcare with that illness. So those are some of the things I can think of without knowing more about the specific situation where someone with diabetes might qualify for palliative care, or how palliative care might be able to help out and help that person live their best life. What other questions are on folks' minds? Are there things that could be helpful to clarify for you, or other situations that would be helpful to talk through?
I have a question. One of our relatives have severe depression, like bipolar, and they're often suicidal. Is that something that palliative care can help with?
It's a great question, Tina. And again, it's a little bit of situation dependent. I think when someone has a major or a pretty difficult psychiatric illness, often starting with the psychiatry team who are specialists in managing that is probably the best place to start. I think that our expertise can be helping someone who might be feeling depressed or anxious because an underlying illness, we can use cancer as an example, is starting to impact their quality of life. I'd say we have some skills in the counseling, providing some extra psychosocial support, and some basic medication management around depression and anxiety medications. But for someone who has a severe psychiatric illness where they have active suicidal thoughts, that person really needs the care of an expert psychiatrist. And that may not be the best fit for a palliative care team. I hope that helps clarify for you, Tina.
Yeah, thank you.
Yeah, great question. And I think that the questions you are asking are really great. And I think if anything, sort of the call to action here is to talk with your doctor if you feel like palliative care might be helpful for you, and your current doctors could help think about your current situation and if it might be a good fit. I hope that today really just helped clarify some of those initial concepts so that when you might be asked the question in the future, what does palliative care mean to you? That you might have more information about helping with those difficult symptoms, improving quality of life, and that it's not just for the end of life or when there's no hope or there aren't other treatment options, that we can really help alongside other doctors throughout the illness course. I'm happy to stick around if there are any other questions. Feel free to put them in the chat. Tina, if there aren't other questions, it's okay with me if we close a little bit early.
Yes.
I'm happy to stick around if there are more questions that come up in the chat, or if people want to unmute themselves to ask live.
One question that Carol has is if you can put the palliative care website on the chat so people can click on it. Yep.
Definitely. Give me just a second. I'll get that website over for you. So that's the website that I just put in the chat for our main landing page. And then we also have a page that is really directed for patients and families. I just put that in as a second part in the chat. And so that has a lot of the information that we covered today, but additional resources available at Stanford, additional community resources for individuals and families living with difficult illness.
Thank you so much. Thank you, Dr. Smith. We appreciate your time.
Of course. And then Tina, I think, is it okay? I can send you my slides and a link to our post-session survey to be sent out later.
Yep, that would be great. Along with these two links, that'll be great.
Excellent. Well, thank you everyone so much for joining today. It was really a pleasure to be here. I hope this information was helpful. If you're able to fill out the post-session survey, it helps us a lot just to make sure we use your all's time well, and that we're communicating well with you all. And thank you so much for having me. What a pleasure.
Thank you, Dr. Smith. Take care.
All
Bye-bye.
right, you too. Thank you. Bye.
Thank you. That's wonderful.